just want to take an informal poll. Who provides obstetrical care in this room? Show of hands, everyone. Who provides gynecological care? All right, lots of people. Who has experienced issues with voiding dysfunction in their patients? It's a very frustrating problem that certainly exists in all our environments. From an obstetrical standpoint, I'm going to concentrate on the postoperative standpoint. There is a certain lack of standardization in terms of care for these patients, and we tend to hold our breath, keep our fingers crossed, and hope for the best with these patients. And I'd like to try and allow us to think ahead and be able to predict some of these voiding dysfunction issues that we're going to have in some of our patients. I have a few disclosures which don't really interfere with this presentation. I want to talk about risk factors, etiology of voiding dysfunction, diagnosis and management. Now, postoperative urinary retention is impaired voiding after a procedure, despite a full bladder that results in an elevated post-void residual. Now, we're going to see different definitions from this standpoint. Typically, the definition that I'll choose is essentially patients that are not voiding more than at least 2/3 of their voided volume have some degree of voiding dysfunction or urinary retention. It's very common. However, it isn't homogeneous across the board in terms of the surgical procedures we provide. So various studies have shown a rate of voiding dysfunction of 2 to 43%. So certainly there are many factors involved that I'll touch on, be it preoperative factors, anesthetic factors, operative factors, and postoperative factors. Typically, a bladder should hold at least 400 milliliters. We do look at how well patients will void, certainly after certain procedures. And we do expect a resolution, certainly within the first few hours, hopefully, a few days, and definitely by 6 weeks. Now, perioperative risk factors. Upon reviewing this literature, a lot of these factors I hadn't taken into account in the past. And some of these are certainly very present in my older patient population. So patients over the age of 50 have a doubling risk of postoperative voiding dysfunction. Taking into account pre-existing urinary problems is important, especially before undergoing procedures such as incontinence procedures that may well provide even more obstruction to already a compromised situation. Neurological conditions. The rate of diabetes is very high back home, and it's certainly something to take into account. Other neurological conditions certainly do play a role as well. So taking a careful history prior to engaging in surgical procedures on these patients is very important. Overdoing it in terms of, we want to hydrate our patients intraoperatively, but we don't want to overdo it either. So certainly if we are providing excessive intravenous fluid, it may result in more distended bladder and urinary retention. Surgery that lasts over 2 hours. Intraoperative anticholinergic use. So certainly have a dialogue with your anesthetist as to what type of anesthetic they're going to provide beforehand and what sort of medications they may be providing intraoperatively. Overuse of opioid analgesia can play a role as well. I touched on incontinence surgery, and that in itself is providing extra support to the bladder neck or to the mid-urethra, and certainly can result in a more restrictive voiding pattern postoperatively. The more radical the surgery we provide, the greater the incidence of urinary retention. Constipation, stool stuck in the rectum that can apply pressure at the bladder base or the urethra can certainly play a role as well. Pain. Although I say we don't want to overdo it with opioid analgesia, we don't want to underdo it either, because certainly pain plays a large role in hypercontracting the pelvic floor and perhaps decreasing the ability to void immediately postoperatively. Excessive blood loss can also play a role. Now, predicting postoperative voiding dysfunction is a challenge. There can be an association, although studies go both ways, and there's so many parallel factors that essentially predicting patients who will undergo issues with voiding dysfunction is a challenge. Certainly, there's a 12-fold increase in patients that are Valsalva voiders, so patients that recruit their abdominal muscles to help void. This can be identified pretty easily on history, or a simple uroflow can help identify these patients. However, the role of preoperative urodynamics in patients undergoing surgery to predict postoperative voiding dysfunction hasn't really been clarified. Perhaps there's a role in identifying, just on a uroflow, the maximal flow rate preoperatively to determine whether or not there's compromise beforehand that may relate to potential voiding dysfunction at the initial void after surgery. A hesitancy in terms of voiding, again, can be demonstrated on uroflow, and this may play a role. Surgery in the anterior compartment, incontinence surgery, these all will play a role in terms of increasing the rate of voiding dysfunction. Now, we can break down the etiology in terms of bladder issues and urethral issues. And broadly, there can be issues with failure of sensation of bladder filling, be it through anesthetic reasons, narcotics, nerve injuries, failure to contract the bladder as well. Again, this is where preoperative voiding dysfunction or the identification can play a certain role. Of course, when we intervene with surgery, as I mentioned, there can be a mechanical obstruction of the urethra, be it with incontinence, prolapse procedures, and then injuries to the bladder or urethra as well. And then from a pain standpoint, functional obstruction of the urethra, be it a very hypercontracted pelvic floor, will not allow proper flow of urine through the opening. Now, various procedures will increase the rate, and as you can see, when we're operating near the bladder, I mean, there is an element of correcting prolapse and perhaps reducing the defects in the anatomy that may predispose a patient to preoperative dysfunction. However, you can see that as we operate near the urethra, as we're more aggressive in terms of our surgeries on the pelvic floor, especially with cases of radical hysterectomies, lower anterior resections by our general surgery colleagues, certainly the rate of voiding dysfunction is significantly high. Now, some of these causes I spoke of before. I will talk a little bit more about regional anesthesia. One important point is that I know in our setting, we have a surgical daycare area where the push is to get patients home as soon as possible to allow proper flow of patients. However, we have to be very cautious in that just because a patient can ambulate post-spinal anesthetic doesn't mean that they can void. There is a delay in that time frame, and certainly we have to allow enough time for these patients to give them a proper trial of voiding. Just because they can ambulate doesn't mean that they can void. Now, bladder overdistention is an issue that comes up in obstetrics and can come up in the postoperative phase as well. So it's very important to keep tabs of how much fluid the patient received intraoperatively, how much time has gone by from the time of surgery. Was an indwelling catheter left intraoperatively? Was fluid left? I tend to try and expedite discharge of my patients post mid-urethral sling, leave a certain amount of fluid in the bladder. I usually leave about 150 to 200 milliliters, so that there isn't too much of a delay in filling the patient. But this has to be communicated to our healthcare providers that will be assessing the voiding of our patients prior to discharge. Think of urethral obstructions. Vaginal packs are commonly used back home, and certainly very important that when a catheter is removed, the pack should be removed at the same time to avoid overdistension issues. Other possible complications would be hematomas or unmasking of other prolapse that may predispose patients to voiding dysfunction. And pain. So I'll dwell on this a little bit. Providing adequate analgesia for our patients postoperatively will allow them better ability to mobilize quicker, to be able to empty their bladder in a more effective manner. Now, epidurals and spinals, they do block the sensory and motor nerve impulses in the sacral spinal cord. There's suppression of the micturition reflex, which can result in decreased detrusor contraction and allow the bladder to have increased capacity. So certainly important to ensure once the patient is ambulating, when they do have a trial of voiding, not to only just measure the amount voided, but to assess how much is left behind, either with an in and out catheter or with a bladder scanner. Now, overdistension injuries can occur. So this occurs when there's greater than 120% of a normal bladder capacity over greater than 24 hours. However, usually this evolves slowly. However, there can be acute overdistension issues that can result in ischemia and quick perfusion-reperfusion injuries that can result in prolonged bladder dysfunction. This is generally the case where I've seen longer-term dysfunction is in our postpartum patients, where there's a lot of distractions, be it care of the newborn, assistance in breastfeeding, mobilization, kind of family members all being ecstatic about and congratulatory to the family, and oftentimes bladder function is kind of set aside, and there needs to be an effort to ensure that the patient is voiding adequately, especially after some of our OASIS tears. Now, how are patients presenting? Typically, there's lower abdominal pain. The bladder is easily palpable when it's overdistended. Subjectively, the patient will be straining to void, and this can be evaluated in terms of a pushing pattern, as you can see in the bottom here, with a simple uroflow. This demonstrates a pushing abdominal-based voiding pattern, which is not very effective in terms of emptying the bladder. A slow urinary stream definitely has a high sensitivity and specificity for predicting an elevated post-void residual. I usually use the rule of two-thirds and a third. So if the patient can void at least two-thirds of their bladder volume, typically they will do well. This needs to be evaluated at a reasonable bladder volume over 200 milliliters to allow for replication of the situation that the patient will have at home, because oftentimes we will be quick to discharge patients and then they'll reemerge through our emergency department to have an indwelling catheter placed. Now, trials of voiding can be done either spontaneously, waiting for the urge to void and to check a post-void residual. In our patients who fail a trial of voiding and are certainly discharged with a indwelling Foley catheter, retrograde filling is certainly an easier option and certainly preferred in terms of standardization of the volume voided. So typically we will fill the patient with 300 milliliters retrograde through the Foley catheter, remove the catheter and do a void. You can measure it in a cap or with a Uroflow device, and you'd like to see at least a voided volume of 200 milliliters. and it's important to assess what type of voiding pattern the patient has. Typically, patients that report a strong stream, subjectively 50% or greater, can safely be discharged home. Now, the key is early identification prior to discharge. The last thing you want to do is discharge a patient and have them pop back through the emergency department, because certainly there can be the risk of overdistension injuries. Teaching intermittent self-catheterization is certainly an option and may be something to consider in the higher risk patients. Patients that are undergoing denervation procedures such as radical hysterectomies may be good candidates to learn in advance intermittent self-catheterization. And this comes into play very importantly as well is the role of pelvic floor physiotherapy, especially in our patients that have a more prolonged situation where there is an assessment of the pelvic floor and there is excessive tightness in the pelvic floor due to pain or other factors. Pelvic floor physiotherapy to help release some of this tightness in the pelvic floor can be beneficial. Now, just moving on to slings quickly. This is an issue that plagues my life as to when is the best time to intervene with regards to mid-urethral sling obstructions. This is very common. I'd like to say that, you know, my 12 years in practice has given me some insight as to how to minimize this. However, as best as we try and standardize and not correct, do a tension-free mid-urethral sling, there is no rhyme or reason, it seems, even taking into account some of the risk factors as to whether a patient will have significant postoperative voiding dysfunction. Retention is an issue, and if patients are not voiding at all, the consideration should be made for an early release of the sling. The release should be done within the first 6 weeks postoperatively to avoid excessive scarring, fibrosis, and healing of the mesh in place, which makes it a whole lot more challenging to access, identify, and release. The resolution of voiding dysfunction is very high upon early identification and release of the sling. However, there is about a 10 to 20% risk of de novo recurrence of the stress urinary incontinence. This is what I tend to do when I'm releasing a sling. I'll do a J cut either at the 3 o'clock position or the 9 o'clock position. As you can see the end. You can see my mouse there. The end of the sling here. I've done a release on the right side of the patient, identifying the sling and leaving some degree of support under the urethra from the left side, allowing for a J that's left behind that will resolve the voiding dysfunction. And studies have shown that there is a lower incidence of recurrence of the stress urinary incontinence. Now, urodynamic studies. When to do them postoperatively. This would be indicated when there's no obvious obstruction on clinical exam. There is no dramatic elevation of the bladder neck or urethra. There is not a hypercontracted pelvic floor. And this may help in terms of identifying an obstruction that is usually defined by a maximal flow rate of less than 15 milliliters per second with a simultaneous detrusor pressure of greater than 20 centimeters of water. So certainly it may help in cases where you can't really identify, is the sling too tight? Is this significant change in the anatomy around the bladder neck, or urethra? Now, voiding dysfunction, I've been in practice long enough now that I'm seeing some of my patients coming back with voiding dysfunction remote from surgery, or patients referred from the community that have had a successful mid-urethral sling that present 3-4 years later with voiding dysfunction. The key is to ensure that there is no injury to the urethra. Cystoscopy would be important to identify whether or not there may have been erosion of the mesh into the urethra, which occurs rarely, but something not to be missed. However, the biggest issue seems to be a recurrence or de novo prolapse that may have been unmasked from previous surgery, resulting in an obstructive voiding pattern. One cautionary story is the patients with mixed incontinence. Mixed incontinence and surgery is a delicate situation because patients with mixed incontinence, their overactive bladder component may allow them to empty their bladder against a tight urethra, allowing overcoming of the urethral resistance. And this should be recognized early because this can result in overdistension issues as well, because the bladder can be overdistended. Patients will accomplish voiding through contractions, involuntary contractions of the bladder. So certainly if patients present with worsening symptoms of overactive bladder after and in combination with voiding dysfunction, this is something that needs to be investigated, certainly with the urodynamic studies. Now overall, what's the take-home message? When we're providing, especially in my field, elective procedures for incontinence or prolapse, the last thing you want to do is leave a patient in worse shape off after surgery than before surgery. I counsel my patients significantly around this issue, and I play the scenario of, I know how much you're suffering from the urinary incontinence presently, but let's play the situation of you being unable to void postoperatively, requiring catheterization, requiring an indwelling catheter, requiring repeat surgery. Certainly that needs to be taken into account prior to partaking in a surgical procedure to try and solve the first problem. There are risk factors that can be identified that we need to review on history. I think adequate communication with our anesthetic colleagues as well will provide, again, a risk stratification leading into the postoperative period. Early identification is important. When we're called to the recovery room, I know we have 100 things to do, but if there is a report that there is perhaps some issues with voiding, certainly send your resident or go to the recovery room to assess the patient and make a decision as to whether or not it is reasonable to discharge the patient without a catheter or with a catheter. Adequate trials of voiding are important. Ensure that other factors are not in play anymore. I can't emphasize enough how some of the anesthetic factors can overlap with some of the surgical factors. So definitely keep these in mind as you're evaluating patients in the postoperative period. In terms of releasing a sling, earlier is generally better. Again, assess whether or not it's the intervention or the sling itself that is providing the obstruction. So an adequate evaluation on history and physical examination of these patients postoperatively will help direct you better as to how best to manage these patients. Thank you very much for your attention.